You feel it, and you tell yourself it is just age. The word that will not come at dinner. The reason you walked into the kitchen, gone by the time you got there. The name of the actor you have watched for 40 years, sitting behind a fog you cannot push through. And every time it happens, you make the same quiet bargain with yourself. This is normal. This is what 65 looks like. But in 2015, researchers publishing in JAMA Internal Medicine followed a group of older adults for years, tracking one specific thing, the pills they took. And they found something that should have changed the conversation in every doctor's office in America. The people with the highest cumulative use of one very common class of medication had a significantly higher risk of developing dementia. Not a rare medication, not something exotic. A class of drugs that sits right now in the nightstand drawers and kitchen cabinets and Sunday pill organizers of millions of people over 65. Some of them are prescriptions you were told to take every single day. Some of them you can buy without seeing a doctor at all. And here's the part that concerns me most. When the memory changes start, almost no one, not the patient, not the family, and too often not even the physician, thinks to look at the pill bottle. They look at the birthday. In the next 20 or so minutes, I am going to walk you through 9 everyday pills that research has linked to shrinking memory, clouded thinking, or outright dementia risk in adults over 65. For each one, I will tell you what it is usually taken for, what the published evidence actually says, and, most importantly, what the safer path forward looks like, because for several of these, there is one. One of these 9 hides in 3 different aisles of your pharmacy under 3 different names, and most people have no idea it is the same ingredient. And the 9th pill on this list is the one your own doctor may call the safest drug in the cabinet, which is exactly why we are saving it for last, and exactly why you must hear the whole story before you touch it. Stay with me, because the order matters, and so does the ending. Here is exactly what you are going to get by the end of this video. First, the full list of 9 medications, named plainly, prescription and over-the-counter, so you can compare them against your own pill organizer tonight. Second, the mechanism, the single chemical messenger in your brain that most of these pills quietly interfere with, explained so clearly you can repeat it to your spouse at breakfast. Third, the finding from a study of more than 170,000 older patients in England that showed not all bladder medications carry the same risk, and which alternative came out looking safer. Fourth, the one drug on this list that does not harm memory directly at all. It starves a specific vitamin instead, and the simple blood test that catches it. And fifth, the exact conversation to have with your doctor or pharmacist this week, including the one thing you must never do on your own, no matter how alarming this list sounds. Now, before we begin, let me be clear about where this is coming from. On this channel, we do not deal in rumor. Every claim I make today is anchored to published research, peer-reviewed journals, major medical institutions, and I will name them out loud as we go so you can look for yourself. This video is educational. It is not medical advice. And nothing here replaces a conversation with a physician who actually knows your chart. Let me tell you about Eleanor. Eleanor is a composite of a pattern I have seen described again and again in the clinical literature and in the letters this channel receives. And I want you to notice how ordinary every single step of her story is. Eleanor is 76. She lives alone in a ranch house outside Dayton, Ohio, the same house since 1989. She takes a purple pill every morning for heartburn and has for 11 years because a doctor started it during a bad stretch of reflux after her husband's funeral, and no one ever stopped it. 3 different physicians have renewed that prescription since. Not one of them started it, and not one of them has ever asked whether she still needs it. She takes a small blue tablet for her overactive bladder, started at 71, because the bathroom trips were ruining her sleep, 4 and 5 wakings a night. And on the nights the sleep still will not come, maybe 3 nights a week, She takes one of those over-the-counter nighttime pain relievers, the ones with PM on the box, because they are sold on an open shelf next to the vitamins, and how dangerous could they be? 3 pills. Every one of them legal, common, and taken exactly as directed. Around 74, Eleanor's daughter noticed the change. Eleanor told the same story twice in one phone call. She missed a hair appointment she had kept for 20 years. She paid the water bill twice in March and not at all in April. The family did what almost every family does. They grieved quietly, assumed it was the beginning of dementia, and started researching memory care facilities that cost, in her area, over $6,000 a month, $72,000 a year, most of it not covered by Medicare. Nobody, in 18 months of worry, ever emptied her medicine cabinet onto the kitchen table and asked a simple question. What is the combined load of all of this on a 76-year-old brain? Because here is what the family did not know. All 3 of Eleanor's pills touch the same territory in the brain. The heartburn pill has been studied for its association with cognitive decline. The bladder pill belongs to a class with one of the strongest published links to dementia risk in older adults. And the PM sleep aid contains the exact ingredient that researchers classify as a strong anticholinergic, the very category that 2015 JAMA Internal Medicine study tied to increased dementia risk with cumulative use. Eleanor was not simply getting old. Eleanor was, very possibly, medicated into fog. And the reason her story matters to you is that her cabinet is not unusual. It is typical. Nearly 90% of adults over 65 take at least one prescription drug, and more than a third take 5 or more, a situation doctors call polypharmacy. If you are over 65 and take even 2 of the 9 pills on today's list, some version of Eleanor's arithmetic is happening in your brain right now. To understand why, you need to meet one molecule. It is called acetylcholine, and I want you to think of it as the brain's librarian. Acetylcholine is a chemical messenger, a neurotransmitter, and one of its central jobs is memory. Deep in the base of your brain sits a small cluster of cells called the nucleus basalis of Maynard, and its job is to pump acetylcholine up into the hippocampus and the cortex, the regions where new memories are filed and old ones are retrieved. When you form a new memory, when you retrieve an old one, when you pay attention long enough to learn a grandchild's schedule, acetylcholine is carrying those signals between your neurons, docking into receptors called muscarinic receptors, like a key into a lock. It is no accident that the main drugs we give to treat Alzheimer's disease, drugs like donepezil, work by trying to raise acetylcholine levels. That is how central this one molecule is to memory. Now, a whole family of medications works by doing the exact opposite, blocking acetylcholine. They are called anticholinergics. Anti, against, cholinergic, referring to acetylcholine. Doctors prescribe them on purpose because blocking acetylcholine elsewhere in the body does useful things. It calms an overactive bladder. It dries a runny nose. It settles a spasming gut. It sedates you enough to sleep. The problem is that many of these drugs do not stay where they are aimed. They cross into the brain, and once there, they block the librarian too. Think about what that means for a moment. Some of the most common drugs in an older person's cabinet are chemically pulling in the opposite direction from the drugs we use to treat dementia. In a younger person, this matters less. The brain has reserve, and the barrier that guards the brain, the blood-brain barrier, is tighter. But after 65, 3 things change at once. The barrier tends to become more permeable, so more of the drug gets in. The kidneys and liver clear drugs more slowly, so a dose that leaves a 40-year-old system by morning can still be circulating in a 75-year-old at lunchtime. And the brain's supply of acetylcholine is already declining with age, so there is less librarian to spare. Take a system that is already running lean, block a portion of what remains, and you get exactly what families describe. Word-finding problems, slowed recall, confusion that everyone blames on the calendar. Now here is the crucial finding from that JAMA Internal Medicine cohort in 2015. The study was led by pharmacist and researcher Shelley Gray at the University of Washington, and it followed 3,434 adults aged 65 and older, none of whom had dementia at the start, for an average of more than 7 years, using pharmacy records rather than memory to reconstruct exactly what each person had actually taken over the previous decade. The risk was not about one pill on one night, it was cumulative. The people in the highest exposure group, roughly the equivalent of taking a strong anticholinergic daily for 3 years or more, had about a 54% higher risk of developing dementia than people with no use. And the association held even when the exposure had occurred years earlier, which raises the sobering possibility that the damage is not always reversible. Which means every additional anticholinergic in the pill organizer is not just adding, it is stacking. Pharmacists even have a term for this, the anticholinergic burden, and researchers like Malaz Bustani at Indiana University have built scoring systems for it, where each drug is rated from 1 to 3 and the numbers are summed. A total score of 3 or more, whether from 1 strong drug or 3 mild ones, is where the cognitive risk climbs. Eleanor's family was counting pills one at a time. Her brain was counting the total. Hold on to that idea, because it explains most of the list you are about to hear. Not all 9 work this way. 2 of them take completely different roads to the same fog. But the anticholinergic burden is the spine of this story. So let us go through them. 9 pills, roughly in order of how easily they sneak into a senior's daily routine, and I will flag the evidence for each as we go. Pill number 1, over-the-counter sleep aids containing diphenhydramine. This is the big one, and it is the one hiding in plain sight. Diphenhydramine is a first-generation antihistamine discovered back in the 1940s, and according to Medline Plus, the National Library of Medicine's drug reference, it is exactly the kind of anticholinergic medication we just described. On the anticholinergic burden scales, it scores a 3, the highest rating. It is the active sleep ingredient in most of those PM products, the nighttime pain formulas, and the standalone sleep aids that millions of retirees reach for 3, 4, 5 nights a week. And notice the irony of how it works. It does not create natural sleep. It sedates you by blocking histamine and acetylcholine in the brain, which is why the sleep it produces is often shallow, and why so many people report waking up groggy, with what feels like a hangover that lasts until noon. In an older adult, the drug's half-life stretches, so a pill taken at 10 at night can still be blocking the librarian at 10 the next morning. Here is what troubles me. The 2015 JAMA Internal Medicine study on cumulative anticholinergic use counted first-generation antihistamines, like this one, among the strong anticholinergics it tracked. And the American Geriatric Society, in its Beers criteria, the standard reference list of medications considered potentially inappropriate for older adults, specifically advises against diphenhydramine as a sleep aid in people over 65. The occasional single dose is one thing, but nightly use, for years, in a person over 65, is precisely the cumulative pattern that study associated with increased dementia risk. If you take a PM product most nights, that is worth a conversation with your doctor this month, not someday. Pill number 2, the same ingredient wearing a different box. This resolves the riddle from the beginning. Diphenhydramine does not only live in the sleep aisle, it is also the classic allergy pill many seniors have trusted since the 1960s, the one most people know by the brand name Benadryl, and it appears again in nighttime cold and flu formulas, usually flagged only by the word nighttime on the package. 3 aisles, 3 boxes. 1 anticholinergic molecule. The pharmacy shelves it by symptom. Your brain files it by chemistry. I have seen medicine cabinets where a person was taking it for allergies in the morning and without realizing it, taking it again for sleep at night, doubling their anticholinergic load with no prescription and no oversight, and no single receipt that would ever tip anyone off. This is why brand names are so dangerous in this conversation, and why the habit that protects you is flipping the box over and reading the words active ingredient every time. If you need an allergy medication after 65, ask your pharmacist about the newer, second-generation antihistamines, drugs like loratadine, cetirizine, and fexofenadine. These were deliberately engineered in the 1980s and 90s to be poor at crossing the blood-brain barrier, which is why they do not cause the same drowsiness and why they carry little to none of the anticholinergic weight. Same allergy relief, dramatically lighter footprint on the librarian. That single swap may be one of the easiest reductions in anticholinergic burden available to you. Pill number 3, benzodiazepines. These are the prescription anxiety and sleep medications, names like lorazepam, alprazolam, and diazepam, a class that has been prescribed to older adults for decades, often continued for years past the point anyone remembers why. Studies of prescribing patterns have found that benzodiazepine use actually rises with age, with roughly 1 in 11 adults over 65 taking one, and older adults are far more likely than younger patients to stay on them long term, which is exactly backwards from what the pharmacology would advise. A 2018 review published in the American Journal of Health System Pharmacy went through the evidence and concluded that benzodiazepine use is linked to cognitive adverse effects in the geriatric population, particularly in patients 65 and older. These drugs work differently from anticholinergics. They amplify GABA, the brain's braking system, essentially turning down the volume on the entire brain rather than blocking one messenger. But the result in an aging brain can look painfully similar. Daytime grogginess, slowed thinking, memory gaps, and, worth adding, a higher risk of falls, which in an older adult can mean a hip fracture. And a hip fracture after 80 carries a mortality risk that most people dramatically underestimate. Part of the problem is simple chemistry. In a young adult, diazepam has a half-life of around 20 hours. In an 80-year-old, it can stretch toward 80 or even 100 hours, which means a nightly pill never fully leaves the body, each dose landing on top of the last. The Beers criteria from the American Geriatric Society lists this entire class as potentially inappropriate in older adults for exactly these reasons. And here is where I must be extremely direct with you. Benzodiazepines are the one class on this list you must never, ever stop abruptly on your own. Sudden withdrawal after long-term use can cause rebound anxiety, confusion, and in the worst cases, seizures. If you have been on one for years, the exit is a slow, physician-supervised taper, often reducing the dose by small steps over months, not days. And for many people, that taper is absolutely worth discussing, because studies of supervised discontinuation in older adults have shown that cognition can improve on the other side. But the discussion happens with your doctor, not with a pill bottle and willpower. Pill number 4, proton pump inhibitors, the PPI. Heartburn pills, drugs like omeprazole, Eleanor's purple pill. These work by shutting down the acid pumps in your stomach lining, and they do that job extremely well, which is part of why they became some of the most widely used drugs in older adults, and among the most likely to be continued for years without review. Guidelines generally envision courses of 4 to 8 weeks for common reflux, yet studies of real-world use suggest that somewhere between a quarter and a half of long-term PPI users have no clear ongoing indication. The prescription simply outlives its purpose. The evidence on cognition here is genuinely mixed, and I will give it to you honestly. A 2017 systematic review in the Journal of Gastroenterology and Hepatology examined the research linking PPI use with cognitive impairment and dementia diagnoses in older populations, and found enough of a signal to take seriously. Then, a 2023 prospective cohort study published in the journal Gastroenterology followed older adults specifically to investigate the association between PPI use and incident dementia and cognitive decline. Researchers are still working out how strong this association truly is, and they have proposed several possible mechanisms, one of which should sound familiar by the end of this video. Because stomach acid is required to free vitamin B12 from food, and long-term acid suppression can quietly erode B12 levels, the same vitamin we will meet again at pill number 8. PPIs remain important, sometimes essential drugs for the right patient. Someone with a bleeding ulcer history or Barrett's esophagus should not touch that prescription without their doctor. The real issue is different. Many seniors are on a PPI with no active reason, a prescription that outlived its purpose by a decade. The question for your doctor is not, is this drug evil? The question is, do I still need this at all? And if I do, am I on the lowest dose that works? Or could I step down to an as-needed approach or a gentler acid reducer? Pill number 5, overactive bladder medications. And this is where the evidence gets remarkably specific. Drugs like oxybutynin are anticholinergics aimed at the bladder. The idea is to block acetylcholine signals to the bladder muscle so it stops contracting at the wrong times. But oxybutynin in particular is a small molecule that crosses the blood-brain barrier easily, and it is notorious for reaching the brain. It scores a 3, the maximum, on the anticholinergic burden scales. A 2024 study in BMJ Medicine looked at more than 170,000 patients aged 55 and older in England, comparing people diagnosed with dementia against matched controls, and asked whether different bladder drugs carry different dementia risk. That is the study I promised you at the top, and its premise alone should change how you talk to your urologist, because it means the risk is not uniform across the class. The older, brain-penetrating drugs like oxybutynin carried the concerning signal. Some of the newer agents in the same class, designed to stay out of the brain, looked meaningfully better. And a 2025 study in the World Journal of Urology compared patients prescribed anticholinergic bladder drugs, including oxybutynin, against patients prescribed a newer drug called mirabegron, which works through an entirely different mechanism. It relaxes the bladder by stimulating what are called beta-3 receptors and is not anticholinergic at all. It does not touch the librarian. If you are taking a bladder pill right now, especially oxybutynin, the sentence to bring to your next appointment is simple. Is there a non-anticholinergic option that would work for me? Do not simply endure the bladder symptoms instead. Untreated urgency ruins sleep and causes falls, and a nighttime fall on the way to the bathroom is its own path to the hospital. But know that within this category, your choices are not all equal, and the published data now says so plainly. Pill number 6, the older antidepressants, the tricyclics, drugs like amitriptyline and doxepin. These are less often used for depression now, but they persist in seniors' regimens for nerve pain, for migraine prevention, and for sleep, frequently at doses of 10 or 25 milligrams that feel harmless, precisely because they are a fraction of the old antidepressant dose. They are not harmless to the acetylcholine system. Amitriptyline scores a 3 on the anticholinergic burden scales, the same maximum rating as diphenhydramine, and that score does not require a large dose. Tricyclic antidepressants sit among the strong anticholinergics, the same broad category that the 2015 JAMA Internal Medicine cohort linked cumulatively to increased dementia risk. In fact, in that study's arithmetic, taking a drug like doxepin daily for more than 3 years was one of the example exposures that defined the highest risk group. A low dose taken every single night for 8 years is exactly the kind of quiet, cumulative exposure that study was measuring. And because it was started for pain or sleep rather than mood, it often escapes the mental category of serious medication in both the patient's mind and the family's. If you are on one of these for pain or sleep rather than depression, There are often alternatives with a far lighter footprint on the brain, different classes for nerve pain, different strategies for sleep. And that is a pharmacist conversation worth having this week. Pill number 7, opioid painkillers. Chronic pain is rampant after 65. Arthritis alone affects roughly half of adults in that age group, and opioids cloud attention and memory while they are in your system. Most people have felt that fog after a surgery. The mechanism is straightforward sedation of the central nervous system, and in older adults it comes bundled with constipation, falls, and dependence. But the research here reveals something more complicated and, frankly, sadder. A 2023 analysis in BMC Medicine examined opioid prescribing in vulnerable older adults with chronic pain and found that those with Alzheimer's disease and related dementias actually received fewer pain medications than cognitively healthy patients. Think about what that means. Once memory declines, patients become less able to advocate for their own pain. They stop asking, or they ask in ways the system does not recognize. Restlessness, agitation, aggression, symptoms that then get treated with sedatives instead of pain relief, which deepens the fog further. That is the second-order trap, undertreated pain masquerading as worsening dementia, and worsening dementia guaranteeing more undertreated pain. So my message on opioids is balance, not fear. Short courses for real pain have their place, and untreated severe pain is itself terrible for cognition. It fragments sleep and floods the body with stress hormones. Long-term use deserves regular review, both for the fog it causes and for the dependence it builds. And if you are caring for someone with dementia, be their advocate on pain. Ask directly whether pain has been assessed, because the data suggests the system quietly stops listening to them. Pill number 8, Metformin. Now pay close attention, because this is the one that does not touch acetylcholine at all. The one I flagged in the promises. Metformin is a cornerstone diabetes drug taken by tens of millions of Americans, genuinely valuable, and I am not telling anyone to fear it, but it has a known nutritional shadow. Long-term metformin use can interfere with vitamin B12, most likely by disrupting the calcium-dependent step your intestine uses to absorb the vitamin in its final stretch. And B12 is essential to nerve function, to the insulation around your nerve fibers, and to cognition. A case report in the journal Age and Aging back in 2006 warned clinicians that metformin-associated B12 deficiency should be considered whenever a user develops cognitive impairment, neuropathy, or anemia. Estimates in the literature since then have suggested that somewhere between 10 and 20% of long-term metformin users develop low or borderline B12, with the risk rising with dose and years of use. And a 2019 study in the Journal of Clinical Endocrinology and Metabolism, following 4,160 older adults, linked both high blood sugar and metformin use with B vitamin deficiency and cognitive dysfunction. Here is why this one belongs on the list, despite metformin's excellent reputation. A B12 deficiency can look exactly like early dementia. Memory loss, fuzzy thinking, numb or tingling feet, unsteady walking, low energy. Families see a diagnosis. It may be a vitamin. And here is the second-order tragedy. The numb feet get referred to a neurologist. The memory gets referred to a memory clinic. The fatigue gets blamed on age. 3 specialists, 3 explanations, and the one $20 blood test that connects all of it never gets ordered. Because the diabetes doctor sees a well-controlled patient. And unlike almost everything else in this video, this one has a clean, cheap answer. A simple B12 blood test, sometimes paired with a follow-up marker called methylmalonic acid when the result is borderline, and supplementation if you are low. Pills for most people, injections for some. Caught early, the symptoms are often reversible. Left for years, the nerve damage may not be. If you have taken metformin for more than a few years and have never had your B12 checked, write that down. It may be the single highest value question in this entire video. And now, pill number 9, the one I promised. The pill your doctor may call the safest drug in the cabinet: statins. The cholesterol pills taken by tens of millions of Americans over 65, roughly half of that entire age group by some estimates. Some people report memory fog or fuzzy thinking on statins, and this is not folklore. In 2012, the FDA added a note to statin labeling, acknowledging rare post-marketing reports of memory loss and confusion, while emphasizing that the reports describe the problem as reversible after stopping. The Mayo Clinic addresses this directly in its patient guidance on statin side effects, discussing the cognitive concerns alongside the benefits and the risks. There is even a plausible reason why experiences might differ from one statin to another. Some statins, like simvastatin, are fat-soluble and cross into the brain more readily, while others, like pravastatin and rosuvastatin, are water-soluble and largely stay out, which is exactly the kind of detail that gives your doctor room to adjust rather than abandon. But here is why I saved this one for last, and why it is different from every other pill on this list. The evidence on statins and memory is genuinely unsettled. Large reviews and randomized trial data have mostly failed to confirm a broad harm. Some studies even hint at protection. The reported fog appears reversible when it occurs, and the protective benefit of statins against heart attack and stroke is, for many patients, large and well established. A stroke, I will remind you, is one of the fastest ways to lose memory permanently, and vascular damage from repeated small strokes is itself a leading cause of dementia. Stopping a statin out of fear could, for the wrong patient, cause the very outcome the fear was about. So the lesson of pill 9 is not stop your statin. The lesson is, if you notice brain fog begin after starting one, that is a real observation worth reporting, not dismissing, and your doctor has options: a different statin, a water-soluble one, a different dose, a careful trial off and back on under supervision to see whether the fog tracks with the drug. This is the pill that teaches the discipline the whole list requires: notice, report, adjust with your physician, never quit alone. Which brings me to the single most powerful move you can make after watching this, and almost nobody over 65 has done it. Pharmacists call it a brown bag review. You take a paper bag and into it goes everything. Every prescription, every over-the-counter bottle, every PM formula, every supplement, every pill you take even occasionally, including the ones in your purse and the ones in the car. The bag matters. Do not bring a handwritten list, because lists contain what you remember, and the entire problem is what nobody remembered. You bring the bag to your pharmacist or your doctor and you ask 3 questions. What is my total anticholinergic burden? Which of these can be stopped, swapped, or lowered? And when was my B12 last checked? Most pharmacies will do this review for free. Medicare even pays for a formal version of it, called a Medication Therapy Management Review, for many patients on multiple drugs. And pharmacists are often the sharpest eyes in medicine for exactly this problem, because they see the whole picture that 4 different prescribing doctors each see a quarter of. The cardiologist knows the heart pills. The urologist knows the bladder pill. Nobody is scoring the sum. There is even a formal name for the fix: deprescribing, a growing movement in geriatric medicine built on the recognition that in older adults, stopping the right drug can be as powerful as starting one. One bag, one conversation, and you will know more about your own cognitive risk from medications than 18 months of worrying ever taught Eleanor's family. One caution: do this with a professional, not as a purge. Several drugs on today's list, the benzodiazepines above all, are dangerous to stop suddenly. The goal is a supervised pruning, never a cliff. So if you take nothing else from the last 20 minutes, take this. The fog that so many people over 65 accept as the price of their birthday is sometimes not age at all. It is arithmetic. The 2015 JAMA Internal Medicine research told us the risk stacks with cumulative use. The BMJ medicine study of more than 170,000 older patients told us that even within a single category, safer choices exist. And the Metformin research told us that sometimes the entire problem is a vitamin no one measured. Your memory is not a lost cause the moment it stutters. Sometimes it is simply buried under a pill organizer that nobody has audited in 10 years. Everything in this video is educational. It is not a diagnosis and it is not a prescription. And every change we discussed belongs in a conversation with your doctor or pharmacist who knows your history and your chart. But that conversation is yours to start. And now you have the names, the studies, and the 3 questions to bring with you. If someone you love, a parent, a spouse, a neighbor, is over 65 and their pill organizer has more than 3 compartments filled, send them this video before their next doctor's appointment, because the brown bag review only happens if somebody asks for it. And if this channel is helping you protect the years you have worked so hard for, subscribe and tap the like button. It truly helps these warnings reach the people who need them most. Take care of yourself, and I will see you at the table next time.